Director at RFH Healthcare. I want to talk something serious today. I just want to answer some questions around COVID-19. We've had we had a pretty difficult situation back in November as a country, Kenya, but then it seems to have improved. But then in February, I think there is reason for us to be quite cautious and very concerned because we are seeing a few more cases. It's creeping up very slowly, but going by what's happening across the world and also other African centers, then it's important for us to be very careful about it. So what you're going to be looking at, let me warn you first and foremost, I'll be showing some images. These are medical images that can be scary to some. It's not extreme in terms of I'm not showing any faces, but I will be showing CT scan images, some of which show diseased lung. And so it's important if that is not your kind of thing, maybe you can just leave a comment and see us in a few. Yeah, here goes. I'll be showing you, these are two CT scans. It's a normal CT scan and an abnormal CT scan for COVID-19. This is a normal lung and an abnormal lung. I'll explain how this comes about and what's different between these two lungs and why this is significant. So when you breathe, when you take in breaths, the part of your body, the system that actually responds to that breath you're taking is your lungs. And your lung is made up of very many small balloons. These balloons are called alveoli. The name doesn't matter, just know that when you breathe in, then there are very tiny balloons in your lung that sort of would be inflated with every breath that you take. Now, they are much, much smaller than this. They're microscopic actually in nature. You have between 300 and 400 million of these. So this is really magnified. But the important thing is to note that with every breath that you're taking, these balloons are going to inflate. And then when you breathe out, they're going to deflate, but not fully. There'll be some air left in the balloon so that they remain open. They don't sort of collapse fully. And this is an illustration. Again, it's important. I'm giving credit to the sites that from which I've borrowed these illustrations. This is from Quizlet.com, and the previous one was from Mayo Clinic, one of the leading health, can I call it an organization because it's more than a hospital in the world, and a great resource. Thank you, team from Mayo. This Quizlet.com also has a very good illustration. And so this is the balloon I was showing you in itself. And outside the balloon, there are very many blood vessels. So these are blood vessels that the blue cells here represent cells that don't have oxygen. And then the red cells are cells that have oxygen. So when you breathe in, this air goes all the way into the balloon, the alveoli. And this is just normal air. What you're seeing here, the air that you breathe normally, it has some oxygen at about 21%. So whatever you're breathing in, 21% of it is oxygen. And it has some carbon dioxide, some nitrogen, some other multiple gases. But essentially, the two gases you're interested in is oxygen and carbon dioxide. Oxygen comes in and carbon dioxide comes out. This is a healthy lung. Now, the way oxygen moves into the blood is passively. It's not forced. This membrane here is very thin. The distance between where the air is and where the cells are, it's a very thin, just very thin membrane. And so just by diffusion, oxygen goes into the cells and carbon dioxide comes out. Just high concentration here, low concentration here, and high concentration here, low concentration here of carbon dioxide and oxygen respectively. Of oxygen and carbon. Again, the important thing to note, to feel it, you need a very thin, the gases can cross very easily without hindrance. Now, when your lungs are diseased, and in particular in COVID-19, when it's very severe, and COVID has multiple levels. The first level is mild, asymptomatic or pre-symptomatic. Then there's mild, then there's moderate, and then there's severe, and then there's critical. I'll explain all of those. Now, in critical and severe, and in a few cases of moderate, what happens is this membrane becomes very leaky. And the blood vessel here begins to seep fluid into this space. And you'll have a lot of fluid accumulating into this airspace. Now what happens? Normally, air cannot displace water. So if this space is filled with water, as much as you're trying to breathe in, air really can't get through. And that's a problem. Begin to see why that's a problem. The second thing that happens is that this space here that air has to cross becomes thicker and it fills with fluid. And so even when air gets into this space, it has a hard time crossing this barrier. As a result, the person who has COVID-19 that is severe or critical, even though they feel as if they're trying to breathe in and it's like their lungs are very tight and they really can't breathe and they're struggling and they breathe very fast to try and compensate for this decrease of the volume of air that can get into the alveoli, to the balloon first. So the balloon space is limited, and then how much blood is getting into the bloodstream, oxygen getting into the bloodstream is so reduced. So if you reduce the amount of oxygen here, this is when you test your blood for oxygen, either by that small thing you put on your finger, it's called a saturated oxygen or SpO2 test, we find that it's less than the value that we'd expect. You and I, with a normal lung, breathing oxygen from the air, that's 21%, you'll find many times your oxygen saturation is ranging 97%, more than 95 certainly for most people, but around 97% thereabout. In COVID-19, when this is quite severe, we've had cases where patients are walking in and oxygen saturation is less than 40%. And they're basically blue, gasping for air. And in some instances, it can be quite dramatic and quite severe. So this is an illustration showing what the airspace would look like. This is the same balloon you're looking at here, but this is now deceased. So you can see a lot of fluid has filled the airspace, and basically there's no room for air to come in. So the air that's coming in is limited, and then this space already is quite thick. Thank you, springernature.com. That's where I got this image from. Now, there are a number of things. When this begins to happen, then we can do a number of things to overcome this process. All we want to do, remember, is just this. We want to get air into your bloodstream, oxygen into your bloodstream, and take carbon dioxide out. And if you can do that, then by and large, over time, we hope that this lung is going to heal. And if it heals, then it will go back to normal. But in the meantime, when you have this, the biggest problem you're facing is getting oxygen into your body. And you need oxygen for your organs to work the normal way. And so the first way we'll overcome this problem is by increasing the concentration of oxygen that you're taking in. So remember, oxygen we breathe normally is 21% from air. So if I give you a bit more oxygen, starting with the nasal prongs, those two tubes that go into the nose, I can increase the oxygen percentage up to 30 something or even 40%. And I can keep increasing this until I give you oxygen by a mask that has a bag. We call that the non-rebreather mask. And that mask, when it's high flow, can give you up to 95% oxygen. And we have other delivery modes, such as the high flow nasal cannula that can give you up to 50 liters of oxygen at some high pressure. And already these modes would allow you to get a lot of oxygen into this small space. What then happens is, even though the volume of air getting to your can I say the balloon is limited, the concentration is almost pure oxygen. So just a little is enough to get into your bloodstream in some cases. Of course, how responsive a person is depends on how severe this damage is. So a lung that is just mildly affected, you may not even need any oxygen. So you'll find maybe the oxygen levels is between 90, above 90%, and you're generally fine. You may feel uncomfortable, definitely some shortness of breath once in a while, but by and large, when you're tested, you may not even need oxygen as such. Then progressively, as this worsens or it's more severe, then you see the instances where even when we give you oxygen via the non-rebreather mask, almost pure oxygen, is not enough. We give you that and your saturations remain in the regions of 60%, 50%, or even 40%, and the patient is dizzying and they're saying, I'm struggling and I can't breathe, and that we witness it and it actually happens. Now, the next thing then that we then do when that happens is now we introduce some form of pressure. We sort of try and push more air forcefully into the lung, because air by natural is a natural nature will not, or gas will not displace fluid. But if you apply some pressure, then you begin to achieve some improvement. So the first thing you're doing, you're using the machine called the ventilator, and the first thing you're going to do is to try and inflate this balloon a little bit more by force. And normally when you breathe out, the balloons collapse a little bit. So we'll increase the pressure at the end of expiration, the time you breathe out, and just keep them a bit more open. That increases the space available for this taking up and taking out of oxygen. And then the second thing is that we are applying actually some pressure, and that pressure will sort of displace some fluid and almost allow for air to get in. And by the time you're using a ventilator, we are giving you pure oxygen, 100% oxygen, which can be delivered through this mode. And there are two ways of delivering that oxygen. One is what we call non-invasive ventilation and invasive ventilation. Non-invasive this is an example of non-invasive ventilation. And what it does is we apply a tight mask over the face and the nose, and then the machine is able to push in air, but there's nothing going in terms of equipment going through the patient's mouth. What we have is just a mask over the face. And by and large, this is the preferred mode of ventilation. If the patient can tolerate it, it can be extremely uncomfortable. That's the first thing. It's technically difficult in many ways. And then it's not, it's slightly less efficacious or slightly less effective than if you do intubation. But then, of course, whenever using a ventilator, then there are risks associated, and therefore we prefer, if a patient could breathe on their own, that is best. And if they couldn't, then we start with an invasive ventilation. If they're able to tolerate that, that's fantastic. But if, despite non-invasive ventilation, oxygenation is not adequate, patient is tiring, the organs are beginning to dysfunction, then now we go to the last option, which is, well, this is not the last option. Last option in Kenya, there's one more. I'll tell you about it. And this is we put in called invasive ventilation. It's invasive because we're putting a tube through your windpipe and then giving you ventilating through that. This is what you see in dramatic movies. Someone is picking, something, pushing a tube into the mouth. Really, normally it's not going through the food pipe; it's going through the windpipe, and through this you're able to give ventilation. Now, this is a bit more effective in delivering oxygen, but has way more risks. And currently, any COVID-19 patient who's gotten to this level, the risk of making it, of not making it, is quite high. Unfortunately, at the time it's needed, it's at a time where if you don't do it, it's almost a guaranteed patient won't make it. So this is that time when we give you do this to give you a chance. And yes, we are seeing improved as knowledge around this disease improves. Then we are seeing a few patients coming through, but it's a really difficult situation. And so I'll take us back then with that understanding to where we were in terms of the normal lung. And maybe actually before that, let me show you the CT scan findings of. So this is a CT scan, and and a CT scan is basically sort of a cross-sectional X-ray. Normally, an X-ray comes from front to back and it puts everything together, but a CT scan allows us to see sort of layers. We'll have more or less some up here, very close to the neck, and then we'll take slices going down all the way, and we can actually see at every level, every layer, how things are. So I will be scrolling down this way, and this is going down all the way to now this is where the diaphragm, the stomach, the liver, the abdomen contents begin to appear. The part we're interested in is the chest in particular. So in this CT scan, let me just give you some orientation. This is the front of this patient, and this I got from radiopedia.org. Thank you just for credits. And then on the back here, we have the spine, this is the backbone. And in between here, we have this is where the spinal cord normally sits. On the side here, these are the ribs, and these are the ribs, and then these are muscles. This relates to the arm to some degree. And then in here, this grayish area This is where the heart sits with the big vessels. So this is more or less the heart, and then there are a big vessel sitting here and a few more um, uh, solid structures. But the part we're interested in is actually these dark looking areas, which are the lungs. We're looking at it as if we're looking from below. So this is the left side and this is the right side. Important part. Normal lung, when you have air, it looks blackish. You can see that. So this is very nice blackish lung that has a lot of air in it. Of course, there's some white. The white we are seeing, there are blood vessels within the lung, and also in some areas we have a little bit of the airways, which will look a little bit, since it has more material, look a bit whitish. But by and large, you want to see a lot of black, and black is good when you're looking at a CT scan of the lung. So keep this in mind so that when you go to the next image, then you are better able to understand the difference. So this is a good lung. This patient is more or less like you and I, breathing in and out. If your lungs are fairly okay and you don't have any difficulty breathing or lung disease, okay? So keep that in mind. The next image I'm going to show you now is a little different. And immediately you can see, compared to what we had before, this one has a lot of white. And compared to the first image that we're looking at, starting from the top almost around the neck, you can see black is more or less just here near the back. Again, you can see the backbone here. You can see the spinal canal there. These are ribs. Okay, the different scanners that were used, but this is where the heart is, and the structures, we call that the mediastinum. But you can see black is just here, a little black here, but most of it is white. Why is it white? Look around the heart, mediastinum, you see a lot of white because there's some blood there. And when you begin to see white here, you're beginning to see fluid. So remember what I told you. Part of the problem that the lungs develop is something called acute respiratory distress syndrome, and that is because a lot of fluid is accumulating within the lungs, and therefore air really can't get in, and that's the crisis you're facing. And in this patient's case, you can see almost the entire lung is affected. Almost the whole lung is quite severely affected, and basically this patient has severe difficulty breathing. Oxygen saturations are way below what they should be. The patient is getting tired, organs are becoming dysfunctional, and essentially this is not this patient really has a tough time and requires urgent assistance. This is critical, and the patient definitely requires some form of support in terms of ventilation. So it's I've had in Kenya we are blessed because about 93% of those who have COVID-19 don't develop this kind of severe symptoms. And COVID-19 when it's very early, it looks like a million things, you know. So or when it's very mild, it can be flu, it can be a small pneumonia, it can be anything. I really can't tell it's COVID just by talking to you or examining you if you don't have massive features. But as it gets worse and worse to a point of being critical, it looks like much fewer diseases. So by the time we are seeing a CT scan of this nature, it's almost a guarantee. I'm saying this because a number of people have had these kinds of images, and they suspect that they have uh, that is not COVID, and we've had these kinds of arguments. And I want to tell you that that's down to something called sensitivity. The PCR test, that is the gold standard for testing COVID-19, has been known to have false negative rates as high as 45%, meaning that the patient has COVID-19, but when you do the test, then you have a negative result, yet the patient has COVID-19 and it's actually killing them, but it's negative because up to 45%, okay, and with improved techniques, the sensitivity is much higher. You can achieve in excess of 70%, but then there's still a really big number of people who have COVID-19, but the test comes back negative. And so now, because of experience, because we've had many of these cases, we can combine many options. One is the clinical presentation. The second is these image findings. And now the radiologist can report CT scans and say this is likely COVID-19. Then there's an antigen test, there's an antibody test, and then PCR is just one. So you have to repeat. So if you have you're meeting your doctors and they're showing you the CT scan and the patient is struggling and they're telling you it's COVID-19, please don't think it's being made up with. This is an extremely difficult disease to manage. Just work with the team, say a prayer, and be one team, because this patient needs tremendous support, not friction. Now, the other part that I would mention is in terms of outcomes. It's when it's this bad, the outcomes generally are very, very difficult. Where we are, we've actually we've sort of we have some advantages in terms of our ability. I work for a level 5 facility, the Airspace Sostro, and we've really gained a lot of experience around this disease. We've made some advancements, and we are probably one of the better centers now in terms of managing the disease. But despite that, despite all the years of experience you have in critical care, despite the team we've put together, it's still an extremely challenging disease. And therefore, what we need to do is to protect those who, when they get COVID, will get this kind of severe disease. I'll tell you something else. Garlic and ginger will not cure this. All right? When you have COVID-19 and you take garlic and ginger and get better, I tell you what, even if you didn't take the garlic and ginger, you will have gotten better, because this is a physical accumulation of fluid. There is no oxygen getting to the lung, and the garlic and ginger will not remove it. Let me surprise you. I actually know garlic. I actually know ginger. The fact that I'm a doctor doesn't take away that knowledge. So I want us to understand that I normally, I've seen the whole spectrum of COVID-19 from family to patients I've treated, and those who have no symptoms, those who have pretty bad symptoms, very severe pain, headaches, joint pains, and they really feel terrible, but they don't have this difficulty breathing, they don't have these kinds of problems. And so in this setup, this is very different from what you have, and there are very many grades. I can come from a crazy situation with COVID-19 and I meet someone with a bottle of ginger saying, no, 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 no. Don't put the patients in ICU, give them garlic and ginger. That is completely out of this world. I'm a firm believer I'm very religious. I'm a firm believer in prayer. We make the prayers. I'm a firm believer in improving immunity and limiting what you're taking in. But I'm telling you, for COVID-19, you better get help when you have a problem of this nature. Yeah, and so maybe then the next thing I want to show us is just side-by-side illustration so that we can see. And I hope you understand what I'm saying, because it's a pretty serious discussion that we're having. And you can leave a comment. As I've said, I'm a bit concerned that where we are heading to, it could be very different. So this is just so that we can see the difference between a normal lung and a COVID-19 lung. And what is crawling on the left side is a normal lung, and what is crawling on the right side is abnormal lung from COVID-19 that is severe, that is critical actually in this case. And remember, there are all those grades. There's asymptomatic or pre-symptomatic, pre being that maybe you don't have symptoms yet, and actually everybody else who gets COVID, they start from either asymptomatic or pre-symptomatic, then they progress. Then there's mild, then there's moderate, then there's severe, then there's critical. And for sure, severe and critical in Kenya, the percentage is about 7% for those who require hospitalization. But that percentage, that's a really big number of people. And for them, it's really, really tough. So we have to protect them. Yeah, so this is it. I hope you have gotten a chance to see what it is that we are dealing with and why it's important for us to be a little bit more cautious in terms of the level of support that we give to our people. Yeah, so that's it, guys. Please do leave a comment. Let me just check before I step out. Let me go into okay, just I'm just checking to see if there's any comment on chat, and I'm not able to see that now, so that in case there is any comment I need to respond to, I can go ahead and respond to that. So I'm also just now heading out to my Facebook, this is also streaming, and if there is a comment on that, I will respond to it right away. And yeah, so I'm seeing Dr. Kikomunini asking for CPD points. Well, good question. Yeah, please remember, and one of the bigger challenges generally we're facing in Kenya is that there are lots of people who don't understand how ICU works, why ICU saves lives, and there's this perception that any patient who's put on life support, that patient is not there. That's number one. Number two, that there is being done for financial reasons, and the people who this thinking sounds good, it's appealing to a certain emotion, but the people giving this wisdom have experience, have absolutely no clue what they're talking about, and it's not prudent to listen. Sometimes, please forgive me for making that very firm comment, but I've seen a lot of very sick people being misled by can I say someone who's overstepping their boundary, and people would come to hospital very, very late because they're listening to somebody who couldn't heal, someone who has no business making a comment about a disease is severe. And yeah, so let's hold our hands together, have this sorted. Let's yeah, any questions, leave them in the comment section. I will be able to respond to that earlier date. And that's it, guys. I'm going to be signing off. Thank you very much for listening. Let me know what you think, any area of improvement, any area of clarification, and any area what can I say? Correction if you find anything that I need to amend, by and large, I think it's well researched. Remember, this is a social presentation to lay people. This is not a CME to the medical people. This is for us to begin to understand what this disease is about. Cheers, guys. Blessed evening and stay safe.